Hello, I'm Marianne Senna. I'm an assistant professor of dermatology at Harvard Medical School, the director of the Hair Academic Innovative Research Unit at Mass General Hospital, and the co-director of the Mass General Hospital Hair Loss Clinic. It is such an honor to be presenting to you today, and I am grateful to the World Trichology Society for the invitation, and to all of you for being here. These are my disclosures, none of which are relevant to this talk. So I have been asked to discuss the environmental factors in cicatricial or scarring alopecia. And I think an important place to start is with the work of Dr. Tsiotsos' group in the UK that showed a significant association at 4 genetic locations for frontal fibrosing alopecia, or FFA. These included a gene that encodes a xenobiotic processing enzyme. And you may be thinking, xenobio, what? Xenobiotic, from the Greek word xenos, meaning stranger, is a substance that is not typically found in an organism that can stimulate an immune or other response. This finding suggested that an environmental factor could be a trigger for disease development in FFA. Now, in thinking about environmental factors, I'd like to start by talking about lithography. Lithography is a printing process that uses a flat stone or metal plate to affix an image using a greasy substance so that the ink will adhere to it. You might be thinking, well, why on earth are we talking about lithography? Well, one of the first cases of lichen planopilaris, or LPP, was described in a young male lithographer in 1909. He was described as a healthy 34-year-old male who developed a patch of scarring alopecia that rapidly progressed to affect the whole scalp over a 3-year period. In the paper, the authors describe, quote, "The baldness was a peculiar type and different from alopecia areata. There was a scaly condition affecting the whole scalp more or less, but chiefly located at the mouths of the follicles that gave way to hair loss and skin atrophy." End quote. What is interesting is that there are significant potential occupational exposures with lithography, including lead and heavy metals, and the use of a chemical called perchloroethylene, or PCE. During plate making for lithographic printing, PCE was used to clean the oily, greasy substances off the plate. An eerily similar case occurred in one of my patients at Mass General Hospital. A young male construction worker developed an intense, acute scalp itch and had a patch of hair fall out while sitting on his couch 2 weeks after initiating ground intrusive construction at a previous dry cleaning facility site. Scalp biopsies revealed lichen planopilaris, and despite aggressive treatment, the patient's hair loss rapidly progressed to involve his whole scalp within 3 years. An official report revealed a high concentration exposure to PCE at the worksite, as PCE is widely used for dry cleaning of fabrics as a degreaser. The patient won a lawsuit against his employer for not providing proper hazmat protection. Now, we also observe a worldwide epidemic increase in cases of LPP and FFA, which has led many to suspect environmental factors in pathogenesis. And I think this quote from Dr. Messenger sums this up nicely. He says, "Frontal fibrosing alopecia was first described by Cosard in 1994 in 6 postmenopausal women. FFA remained rare during the 1990s. However, particularly over the last 10 years, it has become increasingly common, a development that is occurring worldwide. The recent onset and rising incidence of FFA strongly suggests that an environmental factor is involved in the etiology." And we know that LPP and FFA largely affect females, and that females on average use more personal care products per day compared to men. And at least in the United States, these products are completely unregulated by the Food and Drug Administration. Interestingly, a 2017 JAMA Internal Medicine article reported a significant increase in the number of consumer adverse event reporting to the FDA since 2010 for hair care products, specifically shown here in light blue. And 3 hair care companies have been named in costly class action lawsuits since 2012 for causing alopecia. It makes many of us question, what on earth is going on? Is this something toxic, something allergenic? Like other colleagues, we decided to patch test our patients who had LPP and FFA at MGH. To our surprise, out of 42 patients with FFA and or LPP who underwent patch testing, 76% of them tested positively for a clinically relevant allergen in cosmetic and personal care products that they applied to their scalp and face. Now, what's important to note here is that we only counted positive 1 reactions or higher. We did not include plus-minus reactions, which are considered to be equivocal. In addition, we only included in the 76% those that were clinically relevant. For example, if a patient had a +2 reaction to nickel, we did not count that because it was not relevant to anything that was coming into contact with the scalp and face. There were no significant differences in types of relevant allergens between the LPP and FFA patients. And what's interesting is that there were certain ingredients that came up again and again. And when we compare our findings to those of other colleagues, we see that some similar ingredients come up, namely fragrance mixes, linalool, benzophenone 4, MCIMI, balsam of Peru, and others. And when we compare these findings in the LPP and FFA population shown here in blue to the findings of the European general population, which are patients without LPP and FFA, and is probably the best estimate we have for how frequently your average person would develop or be tested positive for an allergen like this, you see that in most cases, the results in the LPP and FFA patient population are significantly higher. In addition, in our study, when patients changed nothing else about their treatment and had been on a consistent regimen for at least 6 months so that nothing else changed, the only new thing was allergen avoidance, 58% of patients reported a decrease in scalp itch, 73% of patients reported decreased scalp redness, and on exam, 70% of patients were noted to have decreased scalp redness as well. And no patient had signs or symptoms of worsening LPP or FFA. Now, what I do not wish to convey is that I think all FFA and LPP is just an allergic contact dermatitis. That is not the case. What I do strongly believe, though, is that whether it is a frank allergy or a noxious stimulus, that there could be something in the chemical ingredients in personal care products that some people's hair follicles just do not like. I believe that repeated exposure may be part of the chain of events as illustrated here. This diagram is adapted from the Pastor Nieto publication cited here that could lead to FFA and LPP development. At the bare minimum, what I tell my patients is that if I had LPP or FFA, I would choose to use products on my face and scalp that do not contain common allergens, even if these allergens are found to have no role in LPP-FFA pathogenesis. Why potentially add inflammation to an inflammatory process? So more work certainly needs to be done to elucidate what this relationship might be. Could exposure to certain chemicals contribute to the collapse of the hair follicle immune privilege or in some other way to LPP and or FFA? Certainly more work will be done to try to figure this out. I thank you all for your attention and again for participating in this wonderful educational forum. And hopefully we will all have the opportunity to meet in person once it is safe to do so. My best wishes to you all. Thank you.